So I'm Sara Manning. I'm one of the Penn Memory Center and the Penn Frontotemporal Dementia Center. And thanks so much for having me. Actually, I was excited to talk with you guys. I actually met my husband when he was studying at Penn Law. So he's not a senior partner yet, but I'm grateful for the to the institution for bringing him to Philly. So, but what we'll talk about today is a thought that I think a lot of people have, which is, am I losing my marbles or am I just getting old? And what about assessing and preventing cognitive decline? So most people worry about their cognition. So even in folks, on the younger side, age 50 to 65, 44% of them are having at least some worry about getting dementia. And it turns out that people who have a family history of dementia and people who have been a caregiver of someone with dementia have a higher likelihood of reporting at least feeling somewhat worried or significantly worried. In reality, the lifetime risk of dementia at age 65, so if you get to age 65, the risk that you're going to have dementia before you pass away is only 25%. So the worry is actually disproportionate to the risk. And even in people who have a family member with dementia, who sometimes will have an increased risk of developing dementia, their worry is disproportionately increased. So in all cases, what we see is the worry outweighs the risk. Hold on one second. There we go.
And Dr. Manning,
so how do we?
Dr. Manning, sorry, just people are asking if you could speak a little bit slower and just try to speak up a little bit because the quality is a little bit rocky. Okay.
Oh, I'm so sorry. Yeah, thanks so much. And just let me know if it's not any better. So how do we think about cognition? It turns out that cognition is actually on a spectrum. So we think about normal, which means normal for your age and education. We think about mild cognitive impairment, and we think about dementia. And we'll talk about each of these categories, but it's really a spectrum and it's fluid. Oops, sorry. Let's see. So thinking on on one far end of the spectrum, what is normal cognitive aging? So it turns out that different cognitive skills peak at different times. But all of them peak by your sort of 50s or 60s or 70s and then start going downhill. And the ones that we usually become more frustrated about actually peak in your 20s. So this was a study that looked at different cognitive tests. And what you can see is here you have on the x-axis, you have age. So what you can see is that there are certain cognitive skills that peak around someone's 50s. We'll look at the next slide that some of them may peak a little bit later. And then there are certain cognitive skills that really peak in your 20s and are just getting worse for most of your life. And the ones that peak earlier are the ones STM is short-term memory. So these were tests where they gave people a family picture and they distracted them and then they asked them to recall what was in the picture and to describe what was there. Or they told them a story and they asked them to recall what was in the story. Or they gave them pairs of words to remember, and then they would give them one word and ask them to remember the pair, and we'll actually do that together in a little bit. And so those, and the last one that peaked early in their 20s was a test where they would give people a sequence of alternating numbers and letters, and then they would have to pick out the numbers and pick out the letters. So it's a test of sort of mental flexibility. And those skills all get worse starting in your 20s, and that's normal. So these are people who don't actually have disease. And then there are certain skills that actually peak later, so more in folks 50s and 60s. And in particular, vocabulary is sort of the best known one. So your vocabulary probably peaks somewhere in your 60s and then starts going down, but it doesn't really drop as drastically. So what we can see is these sort of crystallized abilities. So those are things like vocabulary, also things like knowing facts. So that actually gets better with age until your 60s and then declines. But your fluid cognition or your fluid intelligence, which is your processing speed, that actually declines quite a bit over the course of most of your lifetime. So something like if you hit a detour, you're going to be better at rerouting yourself when you're 20 than you are when you're 60, and that's normal. And so then, what is mild cognitive impairment? What is this sort of middle stage? in order to have a diagnosis of that, what that means is the patient is noticing a problem. We're noticing a problem on our objective testing, but it's not severe enough to qualify as dementia. And we'll get to dementia in just a moment. And so when we think of this mild cognitive impairment stage, about 5 to 15% of people will progress to dementia every year. And about 50% of people will progress to dementia within 5 years. And the reason for that is that there are a lot of causes of mild cognitive impairment. So some of those folks will have Alzheimer's disease. Some of them will have depression that's masquerading as cognitive difficulties, and that can get better. And so it's sort of it's not a uniform group. And then lastly, what is the definition of dementia? So what dementia is it's a syndrome. So it's the loss of cognitive and behavioral functioning to the extent that it interferes with daily life activities. So what this means is there are memory and thinking and behavioral problems that are severe enough that someone can't drive or can't work or can't manage finances or can't grocery shop or can't cook when they used to do those things. And we'll come back to this later, but of course the key is, we want to know a change from baseline. So if you were never a good cook and you're not a good cook now, that's not an indication of dementia or of cognitive impairment. So we don't expect people to acquire skills that they never had. And again, like in mild cognitive impairment, there's actually many causes of dementia. So many people ask, what's the difference between dementia and Alzheimer's disease? It turns out that Alzheimer's disease is the most common cause of dementia, but there are a lot of other causes as well. And importantly, dementia is not a normal part of aging. So loss of cognitive skills is a normal part of aging, but dementia is where that loss becomes severe enough that you actually can't do these basic activities, and that's not normal. So the question then is, how do you know where you fall? And that's part of our job as cognitive neurologists. So what we think about is, what is someone's real world function in 5 different cognitive domains that we'll go over in a moment. And we look for other factors that can contribute to cognitive decline. So it turns out that untreated sleep apnea can actually masquerade as dementia and as cognitive symptoms. The same is true for depression and anxiety. So it's sometimes difficult to pick out those things. Part of our job also is identifying atypical features. So sometimes we'll see folks who have what's called Parkinsonism. So if you can think of someone that you know who has Parkinson's disease, what you probably notice when they move around is that they're a little bit stiff. Their steps are probably a little bit smaller. Their face might be a little bit less expressive. And it turns out that we actually see similar movement problems in some of the cognitive diseases that we see. And that can help point us in the direction of what might be causing someone's symptoms. The other thing that we notice sometimes is people will have well-formed hallucinations. And what that means is they say, I woke up the other night and I saw someone sitting on the edge of my bed, and I knew they weren't real, but they looked real. I have one patient who sees heads floating around her house, and she knows they're not real, but she's seeing them. And that can point us towards particular causes of dementia. We ask about lateralizing signs. So something like patients will come in and say, over the past 6 months, I've stopped being able to use my left hand, or I stopped, being able to use my left foot. And that can point us to particular causes of dementia. And lastly, we look at eye movement abnormalities. So sometimes we'll see people who actually have trouble looking down. And when they go down the stairs, which you can imagine, you have to look down when you go down the stairs, that's particularly hard for them, and they often fall. And then lastly, we do testing to objectively evaluate the skills in every domain. So we'll talk about these domains now. So we think of cognition as being divided into roughly 5 cognitive domains. One of them is memory. One of them is executive function, meaning planning, judgment. It's related to attention as well. We think about visuospatial function, language, and social comportment or social behavior. And the reason we break cognition down into these different groups is because figuring out which area of cognition is impaired actually helps us to determine the cause of symptoms. So again, mild cognitive impairment and dementia are syndromes with many different causes, and figuring out which domains are affected actually helps us figure out the cause. So these are some questions that we often ask folks. And if you can, think back in your own life, do you notice these things? So a question that we ask folks to figure out if there might be memory problems is, are you forgetting recent events? We ask sometimes, are someone repeating themselves in conversation? And that's not always evidence of a memory problem, but can be. For executive function, do you have difficulty multitasking? And the key is it to the point that it's really impairing your function? So as we talked about, everyone is going to have more difficulty multitasking now than you used to, but is it actually a bigger change than we would expect? We ask about visuospatial function. So can someone find items on the counter in front of them? And this is not, we can all think of examples where, you're looking for your keys and you run around the house for 30 minutes and you find it was just sitting there on the table. The visuospatial questions really are geared more towards if you have a bucket of 20 items and I want you to find the keys, are you going to be able to find the keys compared to all the other items? We ask about language. So does someone have difficulty finding words or understanding words? And some word finding difficulty is normal as we age, but sometimes it's out of proportion to what we would expect. And then lastly, we ask about social comportment or social behavior. And that typically we hear someone say, this is totally different than the person that I married. So we'll have folks come in and say, my partner was loving and compassionate and empathic, and now someone dies and they laugh. People can become hypersexual and become obsessed with pornography. And so in particular for those, we have to make sure that when people come in, they bring someone else. So we ask all of our patients to bring someone to their appointment, because as you can imagine, a lot of the symptoms that people have are actually difficult to notice when they're happening to yourself. So having someone else who's a sort of outside observer is often helpful. And the key again is this a significant change from your baseline? So I'll tell you, I was with our son, I think 2 weeks ago, and he asked us to set a timer before he was going to go to sleep. So I said, Alexa, set a timer for 10 minutes. I immediately forgot. I asked her to set another timer, and she says, you have 2 timers. And I asked her how far they were apart, and the response was, you have 1 timer for 9 minutes and 54 seconds, and another timer for 9 minutes and 17 seconds. So I know at my baseline, sometimes I have a 40-second attention span, but that's my baseline. So figuring out what did you used to do compared to what do you do now is very important. So if you have, and let's see if I guess I'm not able to pull off the screen to see you. But if you have a pen and paper, grab a pen and paper, don't write anything yet. Let's see if I can. There we go. So if you have a pen and paper in front of you, don't write anything yet. We'll just do a little bit of some of the tests that you might encounter at the Memory Center and some of the tools that we use to help figure out whether someone's having difficulty. And keep in mind, we don't do the tests in a Zoom meeting with 40 people, so don't read too much into your results. But this way you have a little bit of a taste of some of the tools that we use to assess those different cognitive domains. So I'm going to read a list of these 10 words. Don't write anything yet, but after I read them, I'm going to ask you to write down as many as you can remember. So here we go. The words are hat, bench, purple, daisy, paper, apple, cup, mountain, leash, velvet. Sorry. So I'm going to give you now about a minute or so and write down as many as you can remember.
Apple, purple, leash.
Good, and I'm going to give them to you again. So here's the words again. Hat, bench, purple, daisy, paper, apple, cup, mountain, leash, velvet. And so I'll have you turn the paper over and take another shot and write down as many words as you remember. And so what that is and actually keep them in mind. I'm going to ask you for them again in a little bit. So it's coming back. But so that's a test of your immediate memory. So I've showed you something, I haven't distracted you, and I've asked you to sort of regurgitate the information. And so that's testing both your immediate memory, but it's also testing your language. So someone may have a totally normal memory, but they may have a language problem that makes that difficult. And what you may have noticed over time is the more trials that you do, the more words that you get. So the more trials you do, the more words that you get. And if we did it a third time, you probably would get even more words. And that's what we like to see, is a curve where you get a certain number on the first try, you get more on the second, and you get more on the third. And sometimes when folks have difficulty with attention, that can also make this hard. So you can imagine if you don't pay attention when I give you the list at first, then when you go to remember it, it's going to be quite difficult. So here's another test. In 1 minute, I want you to, and you can do this verbally or you can write them down. I want you to write down as many words as you can that start with the letter S, and no proper nouns, no numbers. And don't use multiple forms of the same word. So if you use the word bike, you wouldn't say biking and biker. So I'll give you about a minute and write down as many words as you can that start with the letter S. Good. So that, it turns out, is, as you might guess, that's a test of language. But it actually is also a test of executive function and sort of organization. As you can imagine, there's no real structure of words that start with S. So what we'd like to see is that someone finds some sort of pattern or regulations for choosing words. So maybe they do rhyming words, or they do words that start with SA, or words that start with, SO, or they do body parts that start with S, or animals that start with S. The key is, can you find some sort of structural way to actually increase your efficiency in getting those words? So that's, again, a task of language and also a task of executive function. Oops, sorry. And this one's a little different, so I'll give you another minute, and I want you to name as many vegetables as you can. Good. So that's, as you can imagine, that's also a test of language, but that actually requires a little bit less executive function, because I've already given you a category. So you may go through, root vegetables, and then, other types of vegetables. So there's some structure, but just by narrowing it down to vegetables, it actually makes it a little bit easier. So it turns out that people will tend to be able to name more vegetables than they will words with S, because it's harder when you don't have that structure. And then but this is a test of visuospatial and executive function. So I'll have you copy down this figure. And so this turns out to be a test, as you can imagine, it's testing your visuospatial function. You have to be able to see the shapes in space and see where they are. But it actually also tests your executive function. So you can imagine, if you have difficulty with organization, you might see these shapes here, but you actually, instead of drawing a line here, can you see my mouse, Jackie?
Yes, I can see it.
Oh, perfect. Okay. So the most efficient thing would be to draw a line here, and then to draw the line here on the diagonal. If you have difficulty with executive function, you might not be able to see that. And so you might actually draw a triangle here, and then you draw another triangle here. You might draw another triangle here. So even though you might end up with the same shape, the way that you get there might be a little bit different. And then sometimes when folks have difficulty with attention, they may leave out one part or another. And don't worry if you left a part out. I didn't give you, a full amount of time. So don't read too much into it, but that's another thing that we sort of sometimes pick up. So I told you this was coming back. Tell me without looking how many of those words, you don't have to tell me, but write down as many of the words that you can. So so I'm now going to give you a list of words, and if you can look through the list and see which ones you think were on that original list. And so this is the answer key, so you have it. But so the original words were mountain, cup, purple, leash, hat, paper, apple, velvet, bench, and daisy. And so interestingly, it actually, as you age, it's going to be more difficult for you to pull out those words by yourself. And that's part of normal aging. But as it turns out, when I give you the words and I say, was this on the list or not on the list, you should still be relatively good at figuring out whether it was on the list or not on the list, even if you can't pull it out yourself. And so what we see in folks, in particular with Alzheimer's disease, is they'll have no idea if the word was on the list or not on the list because they never actually encoded the information to begin with. So the information never got into their brains. So then when we present it, there's no recognition. But in normal aging, for the most part, people will recognize most of the words that were on the list or not on the list. Also, interestingly, as you age, you actually become more conservative in your answers. So you're more likely to tell me that something's not on the list when it was than the reverse. So you're more likely to have a false negative than a false positive. So we don't read too much into it if you tell me that a word wasn't on the list when really it was on the list. But if there's lots of words that you thought were on the list that weren't really on the list, that's more of a red flag. And so this is the last thing I'll do. And I know this is mean. I'll have you turn the paper over. And if you can, from memory, draw as much as you can from that picture. And that one's really tough, and I won't give you the full time, but nobody remembers the whole thing. There's lots of different parts, no matter what age. We don't expect people to remember the whole thing. That's the meanest test that we do in the average cognitive visit, because we don't give you any warning. And so because we haven't given you warning, it's a test of sort of unprompted memory. I didn't tell you that I was going to ask you to remember it. And as you can imagine, it's actually a test of visual memory rather than verbal memory. So when we see a patient who has a particular difficulty with language, we can't test their memory with those word lists, because they're going to have trouble with it because they have a hard time with language. So actually testing it with a picture is actually a better test of their memory. So it allows us to sort of filter out language from memory. So you could put your pens and pencils down. I apologize for making you feel like you're back in law school. But we'll talk a little bit now about, what do we do at the Memory Center, and what kinds of things are helpful to people. And we'll talk at the end about some sort of cognitive tools and tricks. So at the Memory Center, it's a collaborative group of doctors, social workers, there's a nurse practitioner, neuropsychologists, research coordinators. So it's a relatively diverse group. And what we do in part is diagnosis. And that, as we've sort of talked about, that depends on someone's history, their cognitive testing. We also use imaging and blood work. And once we come to a diagnosis, that also helps with prognosis. So lots of people come in with problems with memory. Not all of them are going to progress, and not all of them are likely to progress at the same pace. And the reason for that is because most of them have different reasons for their symptoms. We do use some memory medications. To be honest, they have a real effect in large studies, but it is a relatively small effect. Behavioral treatment, on the other hand, often has a big effect. So treating someone's depression can often have a significant effect on cognition. Treating someone's agitation often has a significant effect on quality of life. We also have research trials, and those are broken down. Some of them are observational, and some of them are interventional, where there's a medication that's being tried. So you probably heard recently there was a medication that received a lot of press that was a potential medication for Alzheimer's disease. That was a drug called aducanumab that targets one of the proteins that builds up in Alzheimer's disease. It was controversial and sort of a unique story, because they had done these two enormous trials at once, and they had done what's called a futility analysis, where they analyzed the statistics midway through the trial, and they decided that the drug didn't work and they were going to stop the trials. And then it took them a few months to stop everything, and then they reanalyzed everything and decided, oh no, there was a big effect. And they actually asked the FDA for approval. And there was a meeting at the end of last week where it turns out the advisory committee decided there wasn't enough information, and they're probably going to have to go back and do more studies. But that's a trial that we participated in, and we participated in a lot of similar trials. We also have a lot of support for family members. Keep in mind that all of these diseases are things that people go through with others. And even though their reality is different from the people who live with them and care for them, the people who live with them and care for them are also going through the same thing, or going through a journey and an experience and a challenge. And then the other thing that's often useful is objective tracking over time. So it allows us to actually compare you to you. So initially, we compare you to other people who are your age and have your education. But as you can imagine, you all went to law school, and even if you're the exact same age, you may not have the same baseline cognitive testing. So then the question is, what can you do? So we think of tips and tricks in two different categories. So there are compensatory strategies, and what that means is working around the problem area. And then there's training, and that's improving the problem area. And it turns out there's probably better data for the compensatory strategies. The training part is a little more dicey. So compensatory strategies are things like using a calendar. I have a patient who, every time I see him, he tells me, 5 times during our visit that he uses a calendar because he doesn't remember that he's told me, but he's actually functioning very well with the calendar. People leave notes around the house, and using alarms for medications can be really useful. The key is make sure that the alarm actually has a name. Otherwise, the alarm's going to go off and people often have no idea why it went off. And then they move on with the rest of their lives. So it becomes less useful. And then there's some data for training. Some randomized studies have showed some success. But there's also been a lot of false advertising and sort of unproven things. So Lumosity, this was in 2016, there was a big case where they had to pay a lot of money because they were advertising things like, decreases the risk of Alzheimer's disease, slows cognitive decline, and it turns out there wasn't really proof for that. So this was a study with cognitive, sort of cognitive training and compensatory strategies, where they asked people to use a calendar, and they broke calendaring down into specific skills. So they said you have one section that has appointments. So those are things that have to happen at a specific time. You have another section that has to-dos, so they can happen at any time, but there are check boxes so you know when you've done it and when you haven't done it. And then there's a third section that's for journaling, and that's for writing down an important event of the day. So something like, you talk to your brother, or, so-and-so called. And it turned out that actually when people did that, and I apologize, the graph is done in a strange way where this is their baseline, this is actually the end, and this is the midway points. So it's a little bit of a weird order. But what we can see is that the people in the control group, by the end of training, actually did a little bit worse. This was a scale where lower was worse. And then the people who actually had the intervention, they actually functioned a little bit better in everyday life. So the people who were calendaring actually performed better in everyday life. And then the other thing that came up in the study is that some people have the calendar, but they, don't know to reference it. So the key was they found, putting it in a place where someone's going to find it, or getting a habit of referring to it regularly. There are other sort of tips that people use. So people use mnemonics, and that's particularly useful for passwords. That's one of the things that people find the hardest to remember is passwords. So one thing that we tell folks is use the first sentence of a song that you love, use the first letters, something like that. So use something that's easier to remember. There's the loci methods, and that takes a little bit more sort of conscious training. But if you have to remember a list of 5 things, imagine yourself going down a path and picking up each of the items. What that allows you to do is expand the list from just something that's verbal to something that's visual and experiential as well. And so you actually encode it a little bit better. And the other is visualization. So this is the last test we'll do, but I'm going to give you some words and some word pairs. So there's a pair: cow and banana, bird and fruit, dress and money, and house and mountain. And so if I give you these pictures, it'll be a little easier for you to remember. So if you remember that there's a cow sitting with bananas, here's a dress made of money, that actually will make it easier for you to remember the pairs. So what about computerized cognitive training, meaning something like Lumosity? There's actually mixed results for that. And part of that is because there's variable populations that are studied, and the interventions are variable too. What we do think is true is if you do those mind games or those computer games, you will get better at the computer games. So you'll probably get better at the task that you're doing. The question is that going to affect you in everyday life? And that's the question that we don't really have a clear answer on. So if you do a memory test, you'll get better at that memory test. But whether that actually is going to improve your everyday function, we just don't know yet. So the bottom line, what do we make of it? What do we actually tell people? We tell folks to choose something that's enjoyable, because if you don't like it, you're not going to do it. And choose something challenging. So you shouldn't be able to multitask while you're doing it. And ideally choose something that has variation or increasing difficulty over time. And lastly, and this is sort of a bonus, choose activities where there's some social engagement or exercise. There was a study recently where they looked at folks who were, they had grown up in a certain community, and the study was matching up groups of 3 to go on walks in the community and look at different places and look at their historical significance. And it actually improved their cognitive function. And it was a small study, but it actually was a nice intervention because it both was sort of intellectual, but it also was social. Another thing we think about is if you like reading, it's great to read a book. It's even better to read a book and talk about it with someone. The other intervention that has fantastic evidence is exercise. This was a study that looked at, it was an intervention where they had people do aerobic exercises, and then they had a control group doing sort of stretching and toning. It was a few times a week, so it was sort of time intensive. And then they looked at the hippocampi. So this is a picture of a brain, if you can imagine a slice going from ear to ear around the top of your head, opening up your face, sorry that that's quite gruesome, and looking straight on, you would see the memory structures. This is the one on the left, this is the one on the right, and they're called hippocampi. And those are the structures that often get smaller in Alzheimer's disease. And as it turns out, in folks who did aerobic exercise, after a year, actually the volume of their hippocampi even got bigger. So actually the brain volume got bigger with exercise compared to those who didn't do aerobic exercise. So there really is just extensive evidence for exercise. And this was a recent paper that was really even more impressive. So this was a study that was done in folks who have a genetic mutation that caused a particular type of dementia. So they're all going to get dementia. But in the folks who were in the highest sort of 25% of exercise, they actually declined about 50% slower than those in the bottom 5% of exercise. So even in people who we know are going to get dementia, exercise has a significant effect. And that's far larger than any medication that we have. So it really is just extremely impressive. And what do we tell people in terms of rule of thumb? We usually say about 30 to 45 minutes, 3 to 4 days a week of something that's aerobic, so something that gets your heart rate up. So yoga and lifting weights isn't going to cut it. Brisk walking, using a bike is better. And as folks age, you have arthritis and other reasons, to have worry, concern about falls. So recumbent bikes actually are often particularly useful. And this was another study just looking at physical activity. It was looking at a score where a higher number is worse. And what they noticed that in people who exercise compared to people who didn't exercise, the people who exercise actually did better on a cognitive test. And so the sort of second to last one is, what about diet? And as it turns out, the data for exercise is more robust than the data for diet. Partly it's a little harder to study diet. It's hard to get people to adhere. If we were to choose a diet, the Mediterranean diet is the one that has the best data. And that's also nicely, that's what your cardiologist is going to recommend. That's what primary care doctors recommend. And that probably has the best data for cognition, but exercise has better data. And lastly, and there's a lot of data for this as well, is social engagement. So this was a study from the late 90s that sort of remained the sort of flagship study for social engagement and cognition. And what they did is it was an observational study. So they looked at folks and they looked at how many sort of social ties do they have. And they counted all of these different sort of categories on the right, and you got a point for each of them. So having a spouse counted as a tie, having a monthly visual contact with 3 or more relatives and friends. And you can see the other different sort of ties. And as it turns out, in terms of the percent of people with cognitive decline, so a higher bar is worse. In the folks who had 0 ties, at 3 and 6 and then 12 years, there was a fair amount who had cognitive decline. Comparably, in the folks who had 5 or 6 ties, at 3 and 6 and 12 years, they actually increased a little bit more. They sort of increased a little bit, but the total percent with cognitive decline was quite a bit lower. So lastly, these were the word pairs that we did. So can you remember the word pairs for cow and bird and dress and house? And what was the second word? Sorry. And I meant to have the icon you may remember. So what may help is you may remember that there was that cow and the banana, and there was the dress made of money in the closet. And so though you probably have an easier time remembering this one and this one than you do the bird and the house. So very lastly, if you care to remember anything from this, I think a big takeaway is some cognitive decline is normal with aging. So if you tell me, I'm worse this year than last year, that doesn't tell me anything about whether there's anything pathologic. The key is it a significant decline that's actually affecting things? And using the history and objective testing together, that's what helps us to identify when something is actually abnormal. And we use these different cognitive domains: memory, executive function, visuospatial function, language, and social behavior to try to narrow down the cause of mild cognitive impairment or dementia. What should you be doing? Exercise, exercise, exercise is really one of the most effective tools. And Mediterranean diet and social engagement too. So I'll stop there. Maybe I'll take off the screen share just so I can see you. And then I think, sorry. Let me just look. So someone asked about, someone asked about sort of average responses. And I can go through and tell you, hold on one sec, let's see, sorry. I lost the presentation. Give me just a moment. So someone asked about, what would we expect you to do what would we expect you to do on these tests? And I apologize for not putting them up. I realized as we were doing it that I probably should have. And the bottom line is, I wouldn't read too much into a single test. This isn't actually, the classic test taking conditions where you're, on screen with lots of other people. But I can tell you sort of on average. So with the 10-word list, and this depends on age, but with the 10-word list, we'd like to see you remember at least, 2 or 3 the first time, 3 or 4 the second time, and somewhere between, 5 or 8 the last time. If you're 50 years out of law school, I could take a guess at how old most of you are, and we're not expecting you to get to 10 words by any means on the 3rd try, and certainly not on the 2nd try. And then in terms of how many do we expect you to remember after a delay, that actually depends on how many you remembered in the first place. So if you only were able to get to 4 words at the beginning, I'm not going to expect you to remember 10 words at the end. So it actually kind of depends on what you get at the beginning. And then when we think about words that start with S, we're looking for something, at least in the sort of 8-ish range. And then for vegetables, we're looking for about 2 more or so. So most people can name sort of, 6 or 8 words that start with S, and they're going to get more like 8 or 10 or 12 vegetables, because it's a little bit of an easier task. But we usually think of the average differential between those as about 2. With the picture, it's a little hard to tell you what's normal, because people make all sorts of changes with them. But the key is, what we would expect is we probably would expect you to remember the rectangle on the outside and at least 1 or 2 of the shapes on the inside. And then with the words, when we asked you to recognize them, we would expect you to remember, of the 10 words, we probably would expect you to get 8 of them or more, where you identify them correctly, or where you identify the false positive correctly. So what we sometimes will see is you identify all of the ones that weren't on the list, but you only identified 7 of the ones that are on the list. And that turns out to be not so abnormal, because that's just what's called a conservative bias, where you're more likely to say, I don't think that was there. versus someone in their 40s is going to say, sure, whatever, that was on the list. And then and then the other question was asking about Prevagen and supplements. And it turns out we don't typically recommend those because it turns out there really isn't enough data to recommend them. So the two really memory drugs that we use, one of them is called donepezil or Aricept. And that one we use for people who have dementia, usually caused by Alzheimer's disease, but there are other types of dementia where we use it as well. And there's another medication called memantine, and we use that for folks in the moderate stage of dementia. But in terms of Prevagen or vitamins, we just don't have enough data to be able to recommend them, and they're often quite expensive. And there's a great question: if a parent has Alzheimer's disease, what's the likelihood of also having Alzheimer's disease? And the answer to that is complicated. If you have one parent who had late onset Alzheimer's disease, meaning it started after they were 65, and there's not, and they have siblings who didn't have it, your risk is actually not particularly increased compared to the average population. It's a really common disease. If you have a parent who had Alzheimer's disease in their 40s and all of their siblings had Alzheimer's disease, your risk is probably going to be increased. And we think most cases of Alzheimer's disease, more than 95%, are actually not genetic. There are other types of dementia that tend to be more genetic, but Alzheimer's disease tends not to be. And there are sort of two types of genes that we think of. There are some that are sort of causative, where if you have the gene, you're going to get the disease. Those typically start in someone's 40s or 50s or even 30s. And then there are some genes that are risk factors, where if you have the gene, you have a higher risk of getting the disease. And those are more common, but still, most cases of Alzheimer's disease are not genetic.
Is there a difference between men and women?
It's a great question. So women actually have a higher rate of Alzheimer's disease. And there's some thought of it, is it because women live longer, and we know that age is a risk factor for Alzheimer's disease, but that doesn't seem to completely explain the phenomenon.
I find in trying to remember things, I use mnemonics.
It's great. Yeah, and that's a great tool. So I think that's a fantastic tool. I'm just looking. And then there was a question about COVID stress exacerbating cognitive decline, and is that temporary, or is that a real implication going forward? And what I would say is it sort of depends what's going on underneath. But for the most part, we think of things as, I will tell you anecdotally, we've seen a decline in cognition in people across the cognitive spectrum in the past 6 or 8 months. It's just extraordinarily common. A lot of it is related to stress. So there's a thought that, if the pandemic starts to resolve, hopefully in, mid to late spring, the stress will start to get better. And that actually should allow people to function better cognitively. What we do see sometimes in folks who have underlying pathology, so in folks who have underlying Alzheimer's disease, if they had Alzheimer's disease before, then sometimes, having such a significant stress for so long, it can be difficult for them to get back to that baseline where they used to be. But we do think that folks will have some improvement. We've, really across the board seen sort of a dip. But we think for most people that's going to be temporary. And that's probably related not only to stress, but also to social isolation. And I think there was one about remembering more words on the first try than the second. And so we do see that sometimes. So it's not uncommon. We'll see someone's, they get 5 words on the first try, and then they only get 3 on the second try. And sometimes that can just suggest an attentional thing. You can feel like you're under pressure. But keep in mind, there's also a lot of variation. So if I give you the same test, if I give it to you every day for a week, you're going to get better at it, but you're not going to get better linearly. There is fluctuations. So you may do worse on it tomorrow and better on it the next day. So that's why we actually tend to follow folks only every sort of 6 to 12 months or so, because the diseases that we see change very slowly, and we don't want to pick up the noise as much. So that certainly does happen. It's not necessarily a red flag at all. So I think those are the ones in the chat, but feel free to speak up if you have any other questions. I think there was one that had come in earlier about do people have do you have trouble remembering things when you get older just because there's more information, which is a great question. I think Jackie, was that it? Okay. So it's a great question. So we do know that if I ask you to remember too many things, it's going to become more difficult. So for example, if we think about digit span, most people can remember about sort of, depending on age, but about 7 numbers. So if I give you a list of 7 numbers, you probably can tell them back to me. And that is easier sort of to remember because it's about the length of a phone number. But if I give you 12 numbers, you're going to do a lot worse because it's just beyond the average person's memory. So in the sort of immediate testing arena, we do think that effect exists. In the sort of arena of aging and sort of long term, there's not evidence that the reason why cognitive aging happens is because there's sort of, too much information. What we think is that normal cognitive aging happens because you actually get shrinking of the connections in the neurons. So a lot of the, if you think about your neuron has 1,000 connections to it has connections to 1,000 different neurons. As we age, those connections actually get pruned. So there's some actual sort of neuronal death, but we think that the bigger issue is actually pruning of those connections. And there may also be an issue of buildup of proteins that actually sort of jam the communication between neurons. And the next one is a hotly contested question about research about cannabis on memory. And it turns out the short answer is we don't know what the effect is yet. So there have been small studies, but part of the issue is supplies are generally not particularly uniform at this point. There is great research for sort of similar treatments in epilepsy, as it turns out. But as far as the effect on cognition, we know in some people it makes them more confused, and in some people we see an improvement in behavior. So we see, anecdotally, we see both ends, but there's just not enough large studies to know, where it falls. So we don't routinely recommend it to people. Anecdotally, I've seen it go both ways.
What about retirement? People who retire versus people who don't.
So it's a great question. So people almost always notice a cognitive decline when they retire. Most people notice it. The key is, what do you do in retirement? So if you retire and then you watch TV all day, that's probably going to cause a significant cognitive decline. If you retire and you're remaining intellectually and socially engaged, then that may not cause much of a decline. The thing about retirement, it sort of goes 2 ways. So one is, if you don't retire, you actually have a sort of easier pathway of getting out of the house every day and remaining intellectually engaged, and it's often socially engaged depending on what you do. The flip side of that coin is sometimes, as people get older, it becomes harder to work, and that can actually cause them to have more anxiety. So even if normal cognitive aging is what's making it difficult for you to work, if you're noticing that can cause a lot of anxiety and can also worsen cognition. So it sort of goes both ways, and it depends on sort of how you're doing as you continue to work. And then there was a question, intellectual activity like reading or bridge or computer stuff, does it delay the onset of dementia? And that's sort of where we sort of stop short of saying that. We don't have enough data to say that it delays the onset of dementia. What we know is, if you play bridge, you'll get better at bridge. If you play Sudoku, you'll get better at Sudoku. But we don't know if that's actually going to prevent you from getting Alzheimer's disease. We don't have the studies to be able to say that. And that's part of what Lumosity, encountered in their lawsuit, is that we can't tell you that it's going to slow cognitive decline. All we know is you can get better at the computer games. But what's the real world effect of that? We just don't know.
How normal is it to forget names?
Very. Yeah, that I would say is, when someone shows up and says, in particular, there are sort of a few rules of thumb that have no data evidence, but are useful in clinic. So when someone shows up and their primary complaint is, I forget people's names, but you're still doing everything you used to do, and you're independent and everything else, that's, a very easy one to say. That's totally within the realm of normal aging. One thing is, when you forget their names, do you recognize who they are for the most part? So if you, forget your niece's name, but you know who she is, I don't read into it, as much. If you forget your niece's name and you have no idea how you're related to her, that's worrisome. The other thing is, how chronic are things? So, are you forgetting someone's name, every day, or is it, from time to time? And
how about remembering faces?
It's a great question. And that one depends a lot on your baseline. So I can tell you at baseline, I have a horrible memory for faces, and it's only getting worse over time. So that really depends. But if memory for faces often is relatively, I would say, benign. Not always. Occasionally we'll have people who have what's called Computerized delusions, which are sort of wild, where they actually will think that someone is an imposter. So we'll have people who say, they look at their husband and they say, you're just an imposter. Where's my husband? You should tell him that I'm with you. And they can't figure out that that's who it is. So sometimes there are more sort of wild and unusual variations, but just not remembering a face, it tends to be relatively benign. There's a part of the brain called the fusiform face gyrus. You have one on both sides, but the one on the right tends to be more important. And sometimes people who have an injury, particularly on the right one, will have trouble recognizing sort of faces and figures. So it can be pathologic, but those are sort of unusual, interesting, rare cases. For the most part, it tends to be benign.
Would you ever consider giving a presentation on the relationship between ischemia and dementia? I think a lot of us, I know I am most interested in TIAs, minimal strokes, major stroke. That's my main concern, my main interest.
Yeah, it's a great question. Sorry, I realized I don't think I had any slides about it. So we do know that vascular disease predisposes to cognitive loss. So someone who has a stroke has a higher likelihood of developing dementia in the time after their stroke. So we know statistically that that's the case. We typically think of it as that you end up with damage, or sort of the most common thing is you have damage to the small blood vessels in your brain. So the same way as you can have a clog in the blood vessels in your heart, you can get the same thing in your brain. It shows up on an MRI as these sort of white spots. And when people have enough of them, that can cause cognitive problems. And the classic cognitive phenotype or profile that we see, although it's variable, the classic one is that you see prominent difficulty with executive function. So, people have a horrible time multitasking. They often have a lot of trouble encoding many of the words on those word lists because they can't pay enough attention to get them in to begin with. So that's sort of the classic phenotype for vascular disease. But it is true, ischemia is ischemic events are an independent risk factor for dementia. What we don't know is, does aspirin or a statin really help? There's data actually that starting an aspirin doesn't actually necessarily help with cognition. So when we see people with vascular cognitive impairment, which is sort of it's the vascular equivalent of mild cognitive impairment, we don't actually, put them on aspirin if they haven't had a discrete stroke, because there's no proof that it helps.
Probably too big an issue for your presentation now, but I'd be very interested in knowing what the advancements are, if any, in diagnosing, treating folks. Like I happen to be 90 years old, so I'm interested in the blood getting to my brain, how to diagnose, whether it's sufficient, et cetera, other than these simple oximeters. So if you ever get around to presenting that, I'd be very interested.
Oh, neat. I will say there hasn't been a big breakthrough in terms of well-accepted interventions. So we're not telling everyone to go out and get their carotids cleaned out. We're not telling everyone, most people are on statins, but we're not putting them on for cognition for the most part, unless there's actually an elevated cholesterol. So I think you may be dissatisfied with it, but that's sort of the state of the field right now.
Thank you.
Okay.
I'd just like to say this was a wonderful program.
Yes, and just to echo that, I've gotten a few messages, Dr. Manning, from people saying that they really enjoyed your presentation and they're really thankful for the knowledge that you shared. And we have a couple announcements that we'd like to make. I know we're a little over time, but we will be doing another Senior Partners event in the spring, so please be on the lookout for that. And also, all CLE credits are free for law school alums now, thanks to the William Carey Foundation gift. So any CLE events going forward, the cost of the credits will be covered by the law school. Okay. And I will be sending a follow-up email after this presentation too, with more information about future events, contact, and where you can find Dr. Manning at the Penn Memory Center as well. So I just wanted to say a few things. I don't know if you have time, Dr. Manning, or if anybody else had more questions, but I just wanted to make those announcements.
Yeah, our son's still sleeping, so I'm around till then. I can't give you an exact time, like a ticking time bomb, but it's still good. It's still ticking. Yeah, but yeah, and thank you so much for having me. This was a treat for me. I was excited, and I think of Penn Law close to my heart. So I also credit it every time I lose an argument, but for the most part, it was helpful.
For those of you who didn't hear in the beginning of the call, Dr. Manning is married to a law school alum, so she's also now a part of our community. So if anybody else has any questions, it sounds like there's still a little bit of time, so you can feel free to speak up or put it in the chat. And also in our follow-up email, we will be sending out a gift to everybody who attended, so make sure that you fill out the survey that will be included in that email.
Thank you, Sarah.
Thank you.
It was great.
Thanks.
Very informative program.
And I'll
Well done.
give I'll put my email in the chat so that you can feel free to send me a message anytime.
Best happy holiday that you can have this year.
You all too. Yeah, happy Thanksgiving and stay safe.
And whatever, it's going on till New Year's, I'm sure. We can't get too far.
You did a terrific job. We appreciate it.
Thank you very much. Thank you, Jackie.
Well, even on Zoom, you're a very warm group, so I appreciate it.
Have to get to your picture.
Okay. And Dr. Manning, is it okay if I share your information in the follow-up email?
Oh yeah, perfect.
Okay.
That sounds.
Yeah. Okay. And she also put it in the chat too for those who wanted to contact her. I think people already want to invite you to speak to other groups as well. So, yeah.
Thanks so much. Thanks for having me. And if you have any questions, don't hesitate to ask. And if I don't know, I can put you in touch with the right people.
Thank you.
Thanks, guys. It was fun.
Thank you. It's great to see everybody.
Bye.
Get safe.
Take care.
Bye-bye. Bye.